Roberge, I'll have you show your video while I introduce you. Welcome. Dr. Roberge is typically in Montreal, but he's joining us from San Antonio, Texas today because he's at a conference. And Dr. Roberge is a full-time professor at the University of Montreal and adjunct professor at McGill University. He is a graduate of the McGill residency program and completed post-residency fellowship at Stanford University and St. Jude Children's Research Hospital. He is currently president-elect of the Canadian Association of Radiation Oncology and incoming co-chair of the CNS, which is the Central Nervous System section of the Canadian Cancer Trials Group. Today, Dr. Roberge's presentation is entitled Use of Tumor Treating Fields in the Management of Brain Tumors, a Canadian Perspective. And I will stop sharing my screen, Dr. Roberge. I'll have you unmute yourself, and then we can get started with your presentation. Thank you for joining us today.
Great. Thank you very much for that kind introduction. So, as you said, I'm a radiation oncologist. I'm going to share a little bit knowledge about tumor treating fields, past research, current research, and try to give it a little bit of a Canadian flavor. Let me just share my presentation here.
Let me know if you need anything, Dr. Roberge.
Yeah, I think we are.
Yep. Looks good.
Looks good?
Yep.
Excellent. So unfortunately, the plan was to have a patient share his experience with us, make this a little less dry, but this was planned a long time ago. And as I presume people attending know, the lives of patients with brain tumors have a way of changing, and he won't be able to join us today. So usually I flash through the conflicts of interest slide, but I think it's important to state that I have had honoraria for research and non-research work with Novocure, which is the company that has developed and provides tumor treating fields. You'll actually see that they've helped me with a lot of the information in the talk, and some of the slides are theirs. So for those that are new to this, and even those that aren't, we'll go a little bit through what is this tumor treating fields, how they've been studied and implemented for recurrent and then primary glioblastoma, clinical trials that are currently available in Canada looking at tumor treating fields for brain malignancies, what exactly the status is in Canada as we speak, and a little bit what the process looks like to get on a tumor treating field. So tumor treating field is an electrical field treatment, but it's delivered through a device. You can see on the picture here, it's labeled the electrical field generator. That's sort of the core of the system that generates the electrical fields, and then it's transmitted to the head and to the tumor inside the head through these transducers that are like these big stickers that go on the skull. So this is the newer generation of the device. It feels a little bit like a power tool and a little bit like your portable drill. It has battery packs that can operate it. But of course, if you're sleeping or you're at a fixed position, it has a plug-in power supply that can plug it into the wall. And then there's all the paraphernalia that goes with this. So how does this work? Why are electrical fields having an impact on cancer? Well, basically these fields disrupt cancer cell division mainly. And as simply as I can explain it, not being a biologist, the cancer cell is trying to divide and make two cells. It duplicates its DNA, and it needs to segregate the DNA to each pole of the cell. And it does this through these structures like microtubules. So there's little tubes that pull the DNA to one side and another. And the orientation and the assembly of these tubes goes haywire when it's disrupted by these electrical currents, and it causes the cell to misdivide and die. There are other effects. So for example, the cell is able to split its DNA, half and half, and it's trying to divide. It's got to sort of pinch the middle and make two cells out of the one cell, and as it's pinching, this causes current effects in that area and also disrupts that cleavage and proper division, and also leads to cell death. So there's other such effects in the cell cycle. When Novocure is deciding what frequency to tune the device to, they can, in the lab, try all the different frequencies on the cancer they're trying to treat. So if it's glioblastoma and, Petri dishes, you have all sorts of glioblastoma cell lines, you try different frequencies, and then you choose the one that seems the most effective. So if the device is for another cancer, it might be a different frequency, but the frequency doesn't get adjusted on a patient per patient basis. So to look at some of the timeline of this treatment, obviously there's a whole timeline before approval, from invention to early clinical trials to more advanced clinical trials, but this is a treatment that's actually been approved in the United States since 2011, initially only for recurrent glioblastoma, but then for upfront adjuvant treatment of glioblastoma. Now in the United States, there's a form of approval for mesothelioma, which is a form of lung cancer, and there's a lot of research looking at other cancers, but really most of the patients and a lot of the work so far has been in primary brain tumors. So in glioblastoma, as I'm sure people are aware, this is the most common primary brain tumor. It's a very difficult tumor to treat. And unfortunately, despite improvements in upfront treatment, it's very common for these tumors to recur, and options can be limited and disappointing at recurrence. So back in 2006, there was a trial that started looking at recurrence, and this could be first, second, third, fourth recurrence, at using tumor treating fields as the sole treatment, or a physician's choice chemotherapy. So it was physician's choice chemotherapy because you can imagine if you're on your third or fourth recurrence, you might have had a different treatment than other patients before, and you want the physician to be able to choose treatment, presumably that the patient's not already received, and that was the most appropriate in that circumstance. So for recurrent glioblastoma, there's a relatively large trial, so almost 240 patients. It's a randomly assigned treatment, so the patients in both groups are very similar as far as their characteristics, and you can see that somewhere around 40% of patients were on their third recurrence and beyond. So these are patients that have had very resistant tumors. So you can see a little bit, this is many years ago, but unfortunately things have not changed that much. These are the agents that patients in the control arm received. So still agents that we see commonly today. So the CCNU, PCV, maybe a different schedule of temozolomide, bevacizumab. And the bottom line is that the outcomes as far as tumor control or tumor response, delaying tumor progression, were similar in both arms. So the median overall survival was somewhere around 6 months. But certainly the tumor treating fields didn't look any worse. And if you look at the progression-free survival at 6 months, which is a common metric for recurrent glioblastoma, if anything, it was a little bit numerically superior than with chemotherapy alone. And if you look at the fraction of long-term survivors, certainly also didn't seem any worse than chemotherapy. If I can illustrate that in a graphical survival curve, you can see that they're similar, but if anything, there's a little bit of a tail on the tumor treating fields curve, and it certainly doesn't seem any worse. As far as progression-free survival is concerned, again, of similar numbers as far as the median, but certainly tumor treating fields didn't seem to do any worse. So if you look at how often the tumor shrank, the response, there are actually a few complete responses in the tumor treating fields arm, something that wasn't seen with chemotherapy, and also some partial responses. You can see that it can take a while for those responses to occur, for median time to response of 8 months. So there can be concern, and basically, if it wasn't clear, this is a treatment that patients do at home with their caregivers. So you basically have these transducers on your head. In the case of this trial, pretty much indefinitely, until tumor progression or until the patient wanted to discontinue. But despite that, as far as symptoms and quality of life, this compared very favorably to chemotherapy. So you can see that bars going up here are improvements in a specific domain, and bars going down are worse symptoms in a specific domain. So you can imagine that, nausea and vomiting with chemotherapy, appetite loss, diarrhea, because there was a fair amount of irinotecan, which is a chemotherapy that's known to cause diarrhea, constipation, what can happen with other chemotherapies, were all much worse with chemotherapy than with tumor treating fields, which really didn't have any domain where there was a large decline in function or increase in symptoms. And even in the overall scales, and you can look here, cognitive function, I don't know if there's some chemo fog playing in here, but again, compared favorably. And as far as adverse events, tumor treating fields, we'll see the side effects are really mainly skin from having these transducers on the scalp continuously, had very few high-grade adverse effects, and it was mainly skin effects. Here we have a picture of a patient with what was categorized as a grade 2 skin irritation. And in the trial and in my experience, these typically don't need to have the treatment stopped. That's something that can be managed by moving the transducers, by skin care, maybe a short pause, but it's something that can resolve and doesn't need to lead to a decrease in treatment or stopping the treatment. So this is somewhat intuitive. I'm not the biggest fan of these sorts of analyses. People that respond to treatment live longer. It's not a surprise, but what's interesting in looking at these graphs is that the responses to tumor treating fields, although they weren't statistically more common maybe than with chemotherapy, they tended to last longer. And so after maybe a brief period where tumor would maybe grow a little bit, you see that maximum response, the response to meet the response criteria at 8 months, and then, responses that are quite durable in those patients that have responses. I think in Canada, we see less prescription of bevacizumab for recurrent glioblastoma than we once did, and this is probably a worldwide trend. But back when this trial was done, there was more prescription of bevacizumab, and more concern that patients that were failing on bevacizumab sometimes were very difficult to treat and had a very quick decline in their function and very short survivals. And in this specific category of patients that had previous bevacizumab, there was maybe an inkling on an unplanned analysis that tumor treating fields maybe performed better than other known treatments. So from this trial and a registry of patients that were treated off trial, this is a lot of the early data that using the device for more hours per day led to better survival and better responses. So in the protocol, the goal was to use it as much as possible, but looking here at an 18-hour cutoff, which is a cutoff that's often used, it really had a significant impact on overall survival if the patients had used it 18 hours or more a day versus less than 18 hours. And in those patients that had a radiological response, that the tumor shrank on the MRI, it was much more likely that there were people that were using it a very high percentage of the time. And as the responses were less good, you can see that the usage in those patients had been lower. So that's recurrent glioblastoma multiforme, and it was adopted, like I said, in 2011 by the FDA in that indication, but subsequently, seeing as so many patients recur after the first treatment, there was a trial looking to move this earlier in the treatment paradigm. So this was trial EF14. So this is a trial that started in 2009 and basically enrolled patients with new diagnoses of glioblastoma, a little bit different than other trials. The patients could already have started their radiation and still enroll in the trial. And they were randomized 2-to-1, either to have, after the chemoradiation, tumor treating fields and temozolomide. The temozolomide was 6 months, which is pretty standard, and the tumor treating fields until second progression or 24 months. So in glioblastoma, it's often difficult after chemoradiation to decide if someone's really progressing or if it's a so-called pseudo progression. So to be sure that treatments wouldn't be interrupted in patients that might still benefit, the treatment was, like I said, continued until second progression. And then the control arm is still standard treatment today, so 6 cycles of adjuvant temozolomide. So almost 700 patients enrolled in the trial. Like I said, randomized 2-to-1 to the intervention. It being a randomized trial, the patients in both groups were very similar. You can see, though, this is a clinical trial. The median performance status of the patients was 90. This basically means that you have almost no symptoms of the brain tumor and are functioning independently, and could basically go back to work if you were able to. So you can see that the treatment, although it was up to second progression or 2 years, the median that it was used was a little bit more than 8 months. So the diagnosis of glioblastoma has changed since then. So there's some patients in this trial that, for example, would have an IDH mutated grade 4 tumor by today's criteria, would no longer be called a glioblastoma, but it's a minority of patients. And to be honest, we still don't have treatments specific to those patients. So probably this would still be considered a treatment for those patients, even though by today's standards, they don't have a glioblastoma. So this is the progression-free survival in this trial. So you can see the top curve is with the tumor treating field. So, a significant difference in how much delay there was in tumor progression. So, from 4 months to 6.7 months, which is quite encouraging. And then more importantly, patients alive, you can see that there's a difference in overall survival that's, from 16 months to 21 months. These numbers are a little bit higher than what we're used to, but I think part of the explanation is that this only includes patients that made it through chemoradiation and were still able to enroll and participate in the trial. Those patients where their condition deteriorated during chemoradiation are obviously not included in this trial. So looking at longer term, so here, for example, to the right, this is what's most exciting about this data to me is patients that are alive 5 years after their diagnosis. And you can see it's 13% versus 5%. So that, I think, is a quite meaningful, both clinically and statistically, difference in long-term survival for these patients. I often get asked if there's some subset of patients for which this is beneficial, or conversely, is there a subset for which it doesn't help? And you can see here, whether it's MGMT promoter methylated, whether it was only a biopsy, or it was a large resection, whether patients were younger, older, had a good performance status or a poor performance status, all categories seem to benefit from the treatment. And I would say even in some of the more adverse prognostic factors actually maybe derived more benefit. So patients that couldn't have a gross total resection and patients that were older, and patients that had a slightly worse performance status. So unsurprisingly, based on patients that had been treated in the recurrent setting, this doesn't add much to toxicity other than the skin toxicity, and that's really the most common toxicity with tumor treating fields. So we talked a little bit in the recurrence, looking at how much the device was used, and you can see here again patients that used it more than 75% of the time versus less, they seem to do better. And this is a correlation where even 70% is better than 60%, but 80% is better than 70%, and 90% is better than 80%. And you can see the gradient of overall survival from those patients that used it less to the ones that were able to use it more. And if you look at really that top category of patients that used it more than 90%, they really had exceptional improvement in outcome versus the rest of the patients. This is obviously, patients are not randomly assigned to use it more or less, and there can be confounding factors that as to why patients were able to use it more. So quality of life, this was extensively studied in the trial. Again, there's some concern that if 18 hours a day, 7 days a week for 2 years, you're walking around or sleeping with a device that's connected to these transducers on your head, even if there was a benefit tumor-wise, this may have a negative impact on quality of life. So there's a whole range of questions that were asked of patients in this trial. So function scales, the higher the bar, the better. That means the function is better. And it's hard to tell looking at this graph which arm is which. There's really not much of a difference in quality of life favorably or unfavorably in comparing the two arms. And then when looks at symptoms, here it's the opposite. A high bar is worse than a low bar. Again, there's no harm in the quality of life from having the tumor treating fields. This is illustrating those things over time. So here, as we go from left to right, we're advancing in time. And if the line goes up, that means the health status is improving. If the line goes down, it's getting worse. And you can see it remains relatively stable. Obviously, the caveat to this is as time goes on, there are patients that are no longer able to complete the questionnaire. And those are probably the patients that were having a deterioration in their condition, mainly because obviously of tumor progression. So the one symptom that's worse with the tumor treating fields is itchy skin or skin bother. And, the cause is obviously related to those transducers on the scalp. But if you look at survival free of worsening of these different quality of life indicators, you can see that apart from the itchy skin, every indicator favored tumor treating fields, even though some of them not in a statistically significant way. So dose. So I'm a radiation oncologist. Radiation oncologists really like to talk about dose. We deliver radiation, dose is in gray, and we spend a lot of time planning radiation for brain tumor patients. Radiation is sort of an intense but intermittent treatment. You get those whatever number of fractions, but let's say 30 treatments over 6 weeks, and it's a few minutes, 5 days a week. Tumor treating fields is the opposite. It's like really continuous for this long period of time, but with short breaks to change the transducers and reshave the head and manage the skin. And we saw one measure of how much treatment a patient is getting. So that's how much time the patient has the transducers on their head with the machine turned on. But there's another factor. It's like, well, while it's on, how much energy is being delivered to that tumor? So there's the field intensity. So that's how much force is being applied by the electric field. Then there's power density, which is how much energy that's delivering per unit volume of tumor or of brain. And then dose density finally is, well, how much power per unit time, and then times how much you had it on your head. So it's a little bit analogous to radiation therapy, but radiation therapy, we do planning, and the interest in that and the control of that is really all on the clinical team. Here, patients have control themselves on what they can do. So, the caregiver and the patient are the ones that manage how much time they're able to use the treatment, and to some extent, the placement of the transducers. So right now, the way it works is that there's a software with a varying number of potential placements for the arrays that's used by staff at Novocure, and based on patients' individual MRIs, they decide on placement of the transducers to optimize how much power density is being delivered to the tumor. And the power density depends on obviously where the arrays are, but also on the white matter versus gray matter, surgical cavity, things in the brain that have different electrical conductivity. And then the way we know, and we'll see examples of reports at the end, the machine can report how much time it's been in use, so that we have some feedback for patient, caregiver, physicians as far as how well the compliance is going. So you can see that, that field intensity correlates with outcome, higher field intensity, better outcomes. The power density, so the energy per unit volume, correlates with outcomes, but even better, that power density times how long it's been used, that's what correlates the best with outcomes. So you can see here all the different combinations. So you can have an array placement that really gives a good power density to the tumor. It's being used a high proportion of the time. That really gives the best results. Then you have the combination of, I'm not using it maybe as often as other patients, but I have a really good plan. And so that's medium. Then the opposite, the plan is not optimal as far as getting power to the tumor, but it's really being used often. And that one makes up for the other. And then there's those patients that it's the combination of both, that the compliance is a little bit difficult, and the delivery based on where the tumor is and the electrodes is a little bit less. So I think in the future, physicians hopefully will have more control on planning this. We'll be able to share that planning with the patient. Patients might get different array placements that they can use and say, well, this one's a little bit better, this one's not as good, but if your skin's getting irritation, you want to shift the transducers around, here's where you can shift them to give your skin a break. So as I spoke in the trial, an adjuvant setting, the treatments were used until second recurrence. So we do have some data. There's no crossover at the first recurrence. So what happens to patients past the first recurrence, whether they had tumor treating fields or not? So at first recurrence, the patients that had tumor treating fields could add another treatment. So you can see here, for example, 33% of patients kept going on the tumor treating fields, but added bevacizumab. But a little bit more than a quarter had just tumor treating fields. And you can see that there seemed to be a survival benefit to continuing tumor treating fields post that first recurrence. So how about ongoing trials? So we only spoke about glioblastoma so far, but tumor treating fields is not a treatment that is adapted only to glioblastoma. Glioblastoma being the most common primary brain tumor is still not that common. Brain metastases in general are much, much, much more common than glioblastoma. And brain metastases from non-small cell lung cancer are the most common brain metastases. So there's preclinical work suggesting that tumor treating fields can have an effect against non-small cell lung cancer cancer cells. And we know that we have therapies that work better for cancer outside the brain and not as well for cancer inside the brain. Whole brain radiotherapy that can be effective in increasing the control of brain metastasis does have a lot of side effects, for example, tiredness and cognitive side effects that the Tumor Treating Fields doesn't have. So the hope is that Tumor Treating Fields can help improve the control of brain metastasis from non-small cell lung cancer. And at the same time, Tumor Treating Fields have the advantage that it can probably be combined with almost any other treatment that the patient requires for the cancer in the rest of their body. So whether they need immunotherapy or chemotherapy or radiation elsewhere, they can still keep doing the Tumor Treating Fields for the disease inside the brain. So this trial randomizes patients with non-small cell lung cancer and brain metastasis to a limited number of areas to either have just radiosurgery, which would be the standard, and of course with whatever best therapy is available for the rest of their cancer, or adding Tumor Treating Fields after the radiosurgery. So like I said, newly diagnosed patients, up to 10 brain metastases. And then we didn't talk about it before, but there's some contraindications in general to Tumor Treating Fields. In the case of glioblastoma, the bone has to be put back. So some patients, because of infection, other reasons, don't have all of their skull in place. So that would be a contraindication. Having a pacemaker or some other battery-operated device implanted in the body that could be interfered with the device is a contraindication. And obviously, if you're allergic to the glue or the hydrogel that's used in the transducers, that would be a contraindication. That would be pretty rare. So the goal of this trial in non-small cell lung cancer is to improve the time to intracranial progression. But obviously, as secondary endpoints, we'll look at very important things like overall survival and quality of life. So I went on clinicaltrials.gov to try to see where this trial was open in Canada. And you can see notably at my site in Montreal, but it's available in several sites in Quebec. And I see that it's open also in Manitoba. Back to glioblastoma. So this is a trial that's opening as we speak in Canada, or just opened in some centers, and it's looking at trying to improve the results in newly diagnosed glioblastoma patients. So there seems to be, again, some preclinical evidence that combining Tumor Treating Fields and radiation can be beneficial, and also that it's safe to deliver radiation to patients that have the transducers on their head. So basically, this is looking to see if starting Tumor Treating Fields earlier, so at the same time as radiation, as opposed to waiting a month after the radiation, can improve patient outcomes. So patients with newly diagnosed glioblastoma are randomized 1-to-1 to either receive standard treatment. In this case, that standard would include the adjuvant Tumor Treating Fields for up to 2 years, or the experimental arm is starting at the same time as radiation. So the device itself is not brought into the radiation room, but just before it's unplugged, radiation, which only lasts a few minutes, and then turned back on. So, and in the lab, that seems to have some synergistic effect from the two treatments, even though they're not instantaneously at the same time. So this is a really big trial. So it's expected to enroll 950 patients in many countries and over many sites. So in Canada, the minimum age to be on the trial is 18. And again, it's the same sort of contraindications to Tumor Treating Fields in general, with the addition of it's pretty rare to have a glioblastoma in the cerebellum or in the posterior fossa, but it's not easy to use the transducers there. So those patients are excluded. So the goal is with this tweak to improve overall survival, but we have all these other important secondary endpoints as well. So The trial, I'm told, is opening next week at my center. So we get the not yet recruiting on the clinical trials site now, but it is currently open in a few centers in Ontario and Quebec. So we've talked about the research and the nature of tumor treating fields in general. I'd like to speak a little bit about Canada. That's why we're here. And Canada has done very well in participating in brain tumor research in general, but also in research with tumor treating fields. So there were several sites in that pivotal trial, like the EF14, that showed the benefit in the adjuvant setting. We saw that there are several sites that are participating in the current trial, looking at adding it at the same time as radiation. And there are also other sites that are participating in trials for lung cancer or pancreatic cancer. So Optune, which is the commercial name for the tumor treating field system, is now approved in several countries. Obviously the USA first, but these other countries that are listed. In Canada, it's not approved yet, but the approval is pending. So if I can touch briefly on my personal experience. So I've treated approximately 50 patients with tumor treating fields. So some of those were on that original trial, the EF14 trial, and I'm privileged to still follow a patient from that original trial. I have obviously the patients with lung cancer, brain metastasis on that trial. And then I have some patients through special access with collaboration from NovoCure that have had it either for recurrent disease or adjuvant disease. So I've had patients since 2013, as young as 16, as old as 81. And I would say probably in part because using the device involves shaving the head, and it seems to be a little bit more acceptable to male patients, and approximately 3/4 of my patients are men. So how does this work, or how would it work in general? Obviously, one sees a physician. In my case, since I see patients sometimes from out of province, some of those appointments are telemedicine to assess the situation, make sure there's no contraindications, that the treatment's appropriate, that the patients understand and their caregivers what's involved with the treatment. And then currently in Canada, it involves asking Health Canada for permission to import a device that doesn't have regulatory approval. It involves asking the manufacturer if they will provide the device on a compassionate basis. There's a prescription, so I need to prescribe the device. I'm prescribing the device for this condition, for this duration. The company has to access the MRI, so to choose the best area on the head to place the transducers to get that best power density, the more dose to the tumor. And then the treatment has to start. So it starts with a teaching session, and that used to be at the hospital, but now, COVID and other reasons, it's can be done at the patient's home or remotely. And this is the patient, the caregiver that's going to be helping the patient, and then a person called a device specialist from the company that comes and does this initiation or teaching session. And then once patients are on treatment, obviously they need follow-up. The follow-up is really not very different from a standard follow-up for a brain tumor. Typically need to be seen at least every 2 months, or if there's some other issue, go over the MRI. Are we continuing treatment, not continuing treatment? How's it going? What's the compliance? Is there any skin toxicity that we can manage? This is an example of what the patient would receive. So it's a schematic of where the transducers need to be placed on the head. And then every month, this is an example of the report that would be provided. So it shows how much the device was used during the month, and then it breaks it down by how much it was used at night versus during the day. Typically, the compliance at night is much better. You put the machine on, put it on the nightstand, and go to sleep. during the day, well, that's when the electrode changes occur. So you can see here, this patient, those regular gaps in the orange bars are the dates that the electrodes or the transducers were changed. And you can see here the overall compliance for this patient is very high. It's 92%. For other patients, for all sorts of reasons, you know what, I was in the emergency room for something. I had a social function I didn't want to wear the device for. I had an MRI, I had to take it off. Then see, here's an example of slightly lower compliance, and we can use this to try to find solutions to improve the compliance. So that's it for my presentation. Again, this is meant to be interactive. In Zoom, it's hard to take questions as we go, but I'll let Yannick manage the questions, and I'm with you to try to share what I know about this treatment.
Perfect. Thank you so much, Dr. Roberge, and thank you for going through the steps of the treatment. That was very, very helpful, and all the great research that's happening around this, around the tumor treating fields. One of the questions that came in was any ideas on timing when Optune will be approved in Canada and where the clinical trials being done?
So I'm not able to say what the timeline is for the approval, but I would hope soon. I mean, soon is never soon enough, of course, but it's definitely in the works. And I apologize. The clinical trials. So the clinical trials, one can always go check on clinicaltrials.gov to be up to date. But I believe was in the presentation. It's currently open in Quebec and in Ontario, I believe.
Great. Thank you. Thank you. Thank you. Another question that popped up was, why do you recommend 75% compliance when more than 90% is so much better?
I'm sorry?
It said, why do you recommend 75% compliance?
Oh, I understand.
Yeah.
So it's just not easy. There's not a large percentage
Sure.
of patients that are able to make the 93. And we always tell patients more is better, but we tried to give them an achievable goal to say, look, we're trying to do at least 75, because based on a lot of that old data where they just chose sort of 75 as the cutoff, but obviously more is better.
Right. Perfect. Okay. Thank you. Will this be available for other brain tumor types? Do you know?
So I don't know that it's approved anywhere on, treatments in general get submitted to some regulatory body, in our case, Health Canada, and a manufacturer will say, I have data showing this improves outcomes in glioblastoma and it's safe, and it gets approved for that purpose. And manufacturers can promote the fact that it can be used for that. But once devices become available, physicians can prescribe it for other tumors. So in the United States, there's a not insignificant proportion of patients that have treatments for, let's say, a grade 3 astrocytoma, which is a very similar tumor than a glioblastoma. So there are other gliomas that are treated, quote unquote, off label with this device. Right. Obviously, we don't have a label yet in Canada. And once it's available in Canada, I assume there'll be requests to use it off label. And then sometimes the issues are, well, funders might only want to fund it for approved reasons, and then it becomes complicated. There's also ongoing research. I didn't talk about, there are different researchers that have their own trials. They're investigator-initiated trials that are supported by Novocure, but for meningiomas or other brain tumors than glial tumors.
Okay, great. Yeah, the next question was, is this applicable to oligodendrogliomas as well? So I think that'll probably answer.
Yeah, so there are patients treated. We don't have good data for anything other than glioblastoma as far as how effective it may or may not be.
Okay, thank you. And another question that just popped up was, how hard is special access? Can most people who want Optune now get it in Canada under special access?
So special access is typically that the Health Canada is not a barrier to getting a device. So Health Canada understands that patients have very serious health conditions, might have limited options, and they're not there to get in the way of the device being imported. I think the issue is just it not being formally commercially available. It's up to, Novocure has been very generous in the past year of accommodating patients, but I can understand that, this can't be indefinitely provided without some form of funding. So As far as I know, there may have been some patients that have gone to the United States to pay for the treatment, but most Canadians that have had this treatment, and certainly those that have received it in Canada, have received it free of charge.
Right. Okay. Thank you. And just one last question. Has gliosarcoma had any research or tests done? Do you know?
So I don't know.
Yeah.
I apologize for not knowing the details if those were excluded or not. They're sometimes excluded from clinical trials, but I would put that in the same basket as IDH mutated grade 4, or someone that has a very aggressive anaplastic astrocytoma, that it would make sense for those patients to be treated. But how the label ends up being interpreted and how funders interpreted that, I don't know.
Okay, perfect. Thank you so much, Dr. Roberge. That was, oh, one more question popped up here. Oh, it just says, wonderful webinar. Thank you for your work, Dr. Roberge. Thank you for hosting Brain Tumor Foundation of Canada. You're welcome. Thank you for joining us today, everybody. Thank you, Dr. Roberge, for taking the time out of your busy schedule for sharing your expertise with us and all this great information about tumor treating fields. And if there's any other questions that pop up or any questions that anybody thinks of after the webinar, please email me directly. Everybody will see my email address on the last slide in a second. I'm just going to wrap up with a couple more things in the door prize. And thank you again, Dr. Roberge. I know you have a flight to catch, so if you have to pop off,
my pleasure. No, I'll stick around. And all right, bye.
Perfect. Thank you. So I'm just going to share my screen again, everyone. Give me 1 second. So we went through the questions and comments. We're going to do the door prize now. So my colleague has sent me the list of names of everyone, and give me 1 second here while I open the right screen so we can get the door prize done. Here we go. Okay. So door prize winner this month is Philippa McDonald. Wonderful. Thank you. I will be in touch with you by email. And just to wrap up the webinar, just a reminder that as soon as you log off to the webinar, a survey is going to pop up. Please just take 2 minutes of your time to complete that for us. We're starting to plan for 2023. As I mentioned earlier, this is the second last webinar of this year. The next one will be on Tuesday, November 22nd with Dr. Daniel Schramrak, who is also a grant recipient from Brain Tumor Foundation of Canada, and he's going to be talking about inherited factors that predispose to brain cancer. We will also have a personal story of hope with Jen Bivelds. And we had originally scheduled a webinar for December, but that's been moved to Tuesday, January 24th. And that's for any parents looking to learn more about mental health of caregivers of children diagnosed with a brain tumor. And as I said, we are working on the 2023 webinar series lineup as well. So make sure you complete that survey. And Novacure is the sponsor of the entire webinar series. So a big thank you to Novacure for basically sponsoring the entire year's 2022 webinar series. We're very grateful to them. And also just a thank you for everybody joining us today and for your wonderful questions and all the chit chat. If you have any other questions, feel free to email me directly, and anybody who registers for this webinar will receive the recording within the next week or so, and we will also have it up on our website. So again, thank you, Dr. Roberge. Thank you everybody for joining us, and have a great rest of the day.